So, and we're getting to the table, to the comparison of the table about the warm and cold and dry and wet factors. And this is going to be related with the therapy as well, okay? So, but before we start, what I want to stress is there's a difference, again, dealing with the acute decompensation of the heart failure and a chronic stable therapy for compensated heart, okay? And watch out, over here. So I'm going to put warm, and here I'm going to put cold, and here I'm going to put dry, and here I'm going to put wet. But what do I mean by warm and cold? What is that? That's the skin. If the skin is warm, in the periphery, if the skin is warm or cold. Okay, so this is a skin. I'll put it in blue. Or green. I'll put it in green. So skin. But what is dry and wet? It's not skin, it's what? If I'm overloaded with fluids or not. So typically it's a lung edema, or leg edema. Depends if it's left or right heart. Okay. So if I'm full of water or not. If the water is somewhere or blood is congested. Okay. So, the first combination, so I'm having a warm skin and a dry lungs. That means there is no edema in the lungs. What this is a compensated or well-compensated situation. So, it's not a severe heart failure because I have a pretty good cardiac output because I'm able to supply the skin. It's warm. There's no vasoconstriction. And it's not so severe that I will have congestion in lungs. So although it's failing, it's okay. So there's some decreased function, but it's okay. So there could be increased fillings of the ventricles or whatever of the pressure, but it's okay. In this case, this is the classical situation where you use what? What drugs will you use to improve the heart? Well, the thing we didn't talk about is the compensatory mechanisms. Okay, and typically, our body is very well prepared for blood loss. Okay. So in case I'm going to lose blood, I'm going to bleed, I'm going to be injured, I'm going to immediately activate what? Sympathetic nervous system. So I will increase the beat, I will increase the contraction, I will do vasoconstriction in periphery, and I will also pump up RAA axis to retain water and ADH. Okay? So these all are compensatory mechanisms. As you know, RAA axis is very important about sodium retention, potassium excretion, and H+ excretion. That's aldosterone. But also, it's very important in angiotensin 2, so vasoconstriction. Okay, so this works, and this is wanted. It's a crucial compensatory reaction, feedback that helps me to survive, to keep my pressures normal in the central part. I want a full load of blood into my heart and to the brain. That's when I'm bleeding. Fine, this works, it should be. But look at the scenario now. The reason why I'm having hypotension is not bleeding, but it's congestive heart failure. So look at that. My heart is already weak. And the way I'm trying to compensate it by increasing the load of the heart by retaining water, sodium and water, so that's the RA axis, ADH, and also increasing the resistance, so increasing afterload. So this is it's a maladaptation. This is contraproductive. This hurts the heart. It's a weak heart and it's getting even bigger load. Okay? So if the skin is warm and I'm dry, so that means I don't have any serious water retention, typically what will I use? What drugs will I use? Drugs that will decrease the frequency of heart, because why? It's load on the heart, and also when the heart is fed by the coronary arteries, in what part of the cycle? In diastole. So I want prolonged diastole to get the blood supply, and let's say I want to decrease the stress of the heart. So I will give beta blockers. And really we know that beta blockers in case of chronic heart failure prolong the life. It's definite. So in this case, I will give beta blockers, and I will also stop the RA axis. So I will give ACE inhibitors. I don't want to have hypertension, okay? I want to decrease the afterload. So I will give ACE inhibitors, I can give angiotensin receptor blockers, I can give spironolactone, which is aldosterone blocker, and this helps the heart. It decreases the load of the heart. So over here, you're going to definitely give beta blockers, and definitely ACE inhibitors, or ARBs, or spironolactone, and other ones, okay? Other scenario, now I'm having cold skin and I'm having dry lungs. So there's no edema of the lungs, but the skin is getting cold. That means what? There's a decreased cardiac output. So now over here I have to be very careful, okay? Because over here, rather, I'm not overloaded by water. There's not too much. Rather, maybe I'm dehydrated, but also the heart is failing. So I can just a bit, maybe just a bit increase infusion, but watch out. If you give a large infusion to failing heart, you're going to kill the heart. So over here, this is if it's due to dehydration, because there is some kind of vasoconstriction or whatever, I can just a bit hydrate, and I can help the heart with inotropes, because now I'm dealing with the hyperperfusion. And that's more serious now, because I can have an acute kidney injury. I can have an acute renal failure due to hypotension. Of course, the brain can be hypotensive, so this is more important now in this case, yeah? So it's a worse scenario. Okay? So, now the combination is that it's a wet and warm. That means, and that's the most typical one, that's when you have a still normal cardiac output in a way. So the skin is warm, but you have a lung edema. And that's typical, that's the most common case you're going to meet. And in this case, you give loop diuretics, because you want to get rid of the water, and you can. And plus or minus, you can give nitrates, which helps the heart. So loop diuretics over here. And the worst scenario is when I'm having lung edema, so I'm wet, or peripheral edema, and cold, because I'm failing like in both ways, in a way, and this is a serious stuff. This person should be at an emergency unit, because he's very likely is going to get into cardiogenic shock, or he's even getting it there, okay? So over here, you fight the decreased pressure first, so you give inotropes, so dobutamine or whatever. So although the heart is weak, I still want to squeeze it more, because this is more important at this time. And even you give vasopressors. So you do vasoconstriction. So it's sort of against the heart, but I want to win the whole body, okay? So I want to save the whole body. So, and when this normalizes, if the perfusion normalizes, then you can give diuretics. After perfusion normalizes, you can decrease the load of the heart. You can give diuretics. Most commonly, of course, you're going to give oxygen and everything to it. But over here, typically use some external help like ECMO or whatever, okay? And by the way, when we're talking about beta blockers, ACE inhibitors, whatever, so this, let's say some kind of, that the cardiac output is okay, there is not a serious congestion, or if there is some congestion, but still cardiac output is okay. Yeah, beta blockers and ACE inhibitors are the most important ones, okay? And these can really improve the life expectancy and prolong the life. But that's in the case of systolic dysfunction, okay? And this is rather, everything is for systolic dysfunction, okay? If it's diastolic dysfunction, I'm stressing again, beta blockers won't help, okay? Or just partially, but typically won't help. And anything you do, any therapy, it's just a, let's say, improve the symptoms, but not prolong the life. So it's not reversing the process. If it's hypertrophy, whatever, it will only improve the life, okay? So you can use some diuretics or whatever, and ACE inhibitors, they could help partially. You don't give beta blockers. Also, when there is an acute failure and when there is a decreased cardiac output, like serious, when you're having hypoperfusion, when the skin is cold, will you be using beta blockers? No, because you will slow down the heart, you will send it to shock, okay? So always you have to figure out in what situation the patient is and then react to it. So you have to be very wise. And yeah, you cannot use beta blockers if already he's failing. He has a pressure like 90/60 or 80/50. You cannot give beta blockers, otherwise you'll stop the heart. Get it? Okay, so that's it for today. So thank you very much and see you next time. Okay? Yeah.
You will be with us next week also?
Very likely.
Wow, nice.
So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.